Good morning, colleagues. I am truly honored to COGS for this opportunity, specifically COGS Central Branch through our chair, Dr. Simon Kigondu. I am very honored to be here speaking in front of colleagues. So today, or rather right now, we are going to switch gears a little bit. I am aspiring to be like Dr. Sarita, a frog in future, but just exploring the field of infertility. I realize it's a big problem, not only in our community, but in the nation at large. So today I want to focus a little bit on the men, and my purpose really is to open our eyes to this other half of the infertility equation, okay? And basically doing what I'm referring there to reframing the male infertility in modern reproductive medicine. Just declaring my conflicts, my sponsorship was through a pharmaceutical for registration. By the end of this talk, my hope is that you'll have a good understanding of the definition and background of infertility. We'll remind ourselves a little bit about the physiology of spermatogenesis. You cannot talk about male infertility and not touch on seminalysis, so I'll touch on it a little bit. And we need to appreciate the causes of male infertility, and ultimately we'll look at the management options for the same. So as a way of introduction, let us look at the magnitude of the issue, first by defining infertility. As we all know, infertility is 1 year of inability to conceive despite regular and protected intercourse. It can be primary or secondary. So I know we also know that age plays a factor, not in the definition of infertility, but as to when should we be aggressive about it. Because I know we all know that women after the age of 35, we use 6 months as a point of coming in to do investigations. It affects 1 in 6 people, so it's fairly common, okay? So in this room, if we are 20-some, we can say 1, 2, 3, 4, 5, 6, you're 8, like that, right? So it's quite common, and therefore a burden in the world. And it's also important to appreciate that this may be an underreporting because not so many people seek medical care due to infertility, so it could really be underreported. There's also the impact beyond the simple inability to conceive. There are spillover effects, right from stigma in society, domestic violence, which includes intimate partner violence, divorce rates, depression, anxiety, even substance abuse. So much more comes with infertility. And from what we have seen is that it's actually on the rise, perhaps because more people are seeking care, we are documenting more, but it could also be lifestyle changes tipping us over to infertility. So I want you to look at this slide so that we understand the contribution of males and females in terms of infertility. When you look at the male factor, it's 30%, female factor, 30%, but there's the combined factor, which is 20%. So when we say that males contribute to half of the infertility statement, this is where infertility burden, this is where it comes from. 30% purely male, but there's additional 20% where it's both the male and the female. So that's significant. How many of you see both the male and the female coming to the clinic? Yeah? I can safely say that majority are the women. It's always assumed. Why is that? Perhaps, the woman carries the pregnancy. It's more obvious if she doesn't end up pregnant. But it takes 2, right? So it's very important for us to start sensitizing our men to come for clinic beyond the cultural perceptions of male infertility. Did you know sperm counts are going down? Men in the room, did you know? You're having less sperm counts than your grandparents. So I think this is something that has come up. There are systematic reviews that have looked at this. The initial ones had methodology issues. So you can see when you look at, let me just do the pointer so that we can go together. When you look at the decline slope before 1972, there was a decline, yes, but it appears to be sharper beyond 2000. And this is a bit of just the data being put together, how clear was the methodology, etc. But it's without a doubt that the sperm count is going down. Back in 1973, the average sperm count was 101 million. 2018 had come down to 49, okay? And this included sub-Saharan Africa, so you're not excused from this data. Yeah? So I think it's good to appreciate that and understand what does this mean from a public health point of view for the future. Currently, we're not seeing a decline in the global population, so people are still having children. It might be just some regions are having less. China, for example, there's restrictions. Sub-Saharan Africa, access to contraception, etc., is a challenge. So we're still having several children, but we need to appreciate the count is going down. And there are possible explanations to this. There are more smokers right now, substance abuse, alcohol, and even at a younger age than before. And this could have negative effects on sperm production. Psychological stressors. I mean, those who travel from Nairobi, you're beating traffic to get here. In the traffic, there's fumes, all that. So stressors could affect the efficiency of the sperm production. Obesity, definitely on the rise. Insufficient sleep, people are low coming here, there, so doctors, we are high risk a little there. Yeah, so it's important to understand and appreciate the value of a normal physiology in supporting basic physiological functions, which you don't have to wake up and think about today, let me produce 100 sperms, tomorrow, etc. It's in the background happening. So other things, pollutants, heavy metals, industry workers, all exposed. So why male infertility and why does it matter? And I think for me, after having spent some time in this particular topic, I appreciated that in undergrad, postgrad, we didn't spend a lot of time on the male infertility. And look, it contributes to 50%. So we need more awareness amongst ourselves, and which is why I'm sharing it with you today. And why so? We've already appreciated about 50% of cases are due to the male factor. Number two, definitely under-investigated. They do not come. When they come, you give a semen analysis request, they never come back. So beyond the point of contact, they don't follow through. The other issue is that it's an opportunity for treating other conditions. When a man comes to your clinic and has erectile dysfunction, it is not just a sexual function disorder. This man probably has microvascular disease. He's a heart attack waiting to happen as well. It could be diabetes in the background, poorly controlled, undiagnosed. So it's an opportunity to pick up other things. It is just a tip of the iceberg. And therefore, yes, as I put in the next point, it can indicate systemic disease. There are also genetic anomalies that are associated with male infertility. And with these genetic anomalies, there are other risk factors, cancer risk, etc. So it's a point of entry. And of course, the psychosocial impact, the effect on the relationship, the man standing in society because he's never fathered a child. So all those are important to consider. And as we say, both partners, evaluate them simultaneously as much as possible. I think it's also very important how we frame our next steps forward. It's important to tell them that the issue may be the woman, maybe the man, maybe both, but keep an open mind. So we are not pointing fingers way in advance. So this is a reminder from undergrad, postgrad, wherever you remember it from, but you cannot understand male infertility without going back to the basic physiology. Just a reminder, the signals from the hypothalamus to the pituitary and down to the gonads. And any issue along that is disrupted, if there's any disruption anywhere along that system, then we have issues of sperm production or sexual function. And therefore, all our tests are geared at where is the issue, at what level do we have the issue. So when you remember this cycle, then you're able to pinpoint. What I want you to take from this slide as well is that spermatogenesis will take you about 74 hours. What does that mean? If you institute management that you're hoping to improve sperm count, for example, there's no point of doing a semen analysis today. In a month's time, you're doing another one. You haven't given time for a full cycle and a new set of gametes to be viewed through a semen analysis. So please let's remember that. Body temperature, the way God designed it is that the scrotum is outside, cooled, so lower body temperature. So when you find people with issues of spermatogenesis and they have a background of wearing very tight pants, going to the sauna, hot baths, there are some who will do it and still have normal counts, but there are others who are struggling. You want to eliminate factors that could hinder sperm production. So, yeah. Next, knowing what we know now, this is a simple way to approach male infertility. When you're looking at a man man, woman, they're struggling to conceive, when you focus on the man, you need to look at where could the issue be. And I find this a very useful template to use when you're trying to determine where the issues are. You look at it, is it a driver system? A driver system means, is the hormone system intact? Your GnRH, your gonadotropins, are they being produced the way they should be produced? Are there other factors interfering with the drivers, the fuel for the process? And that's what we call pretesticular causes. Next, look at, could the cause be in the factory, which is at the testicular level? Have we damaged the production through toxins, through a genetic issue that causes arrest of production of the sperms? So has there been a history of infection like mumps that interfered with the primary production? Or could it be a problem with the delivery? So the fuel, the driver is working, the factory is working, but there's an issue with the delivery. If a man cannot then have an erection and ejaculate, then despite the millions of sperms being produced, you cannot achieve a pregnancy. So it's very important to look at it from those three different angles. I'm going to touch on them just briefly. I don't want to overwhelm with info. I just need you to get to the awareness stage so that you know when you're handling a male, there are all these things to look into. Pretesticular, as I said, it's the drivers of the system. When you look at those two men on the screen, do you think there's one who has more of a problem than the other? Are they both okay? What do you think? Huh? I know everyone's looking at the obese guy and saying, hapo ni kubaya. It is true, he has an issue. What did you say about scrotal temperatures? They need to be lower. Do you think he's lower? Probably not, yeah? So there's that. But beyond that, he's at risk of diabetes type 2. Number 2, obesity in itself causes a functional hypothalamic dysfunction, meaning that the obese men have higher circulating estrogen, right? What does estrogen do to the GnRH production and therefore the gonadotropins? It causes a negative feedback. So you find their sperm production goes down. Then the fit guy could also be at risk, okay? I'll tell you this. When men are trying to bodybuild, there's always a temptation to use exogenous anabolic steroids. Anabolic steroids give a negative feedback. So when you give a negative feedback to the hypothalamus, what happens? Your FSH, LH, they go down. So what happens to sperm production? Goes down. So they may look good, and I think this is caution for the women. They may look good, but ultimately they may be a challenge, okay? So just appreciate that element. Some do it naturally, but others use anabolic steroids. And the caution here is that it is reversible to some extent. Some have complete reversal, others may never have complete reversal. So it can do more harm than good. Chronic illness, hyperprolactinemia, let me mention that because I think we look at it more in females, that it causes menstrual irregularities. It's easy to pick, okay? So they get oligomenorrhea or secondary amenorrhea. You can pick it early. For men, it's a disruption of their sexual function. The libido goes down, etc. So you need to do the prolactin levels as a standard because it's correctable. We think male infertility is always IVF, we need to harvest sperms, but no, sometimes there are correctable issues, including putting them on cabergoline to reduce the prolactin. Good. In the factory itself, what could go wrong? Varicocele are a cause, which is also correctable, but let me put caution there, not all varicoceles. If you've not picked them clinically and he just goes for a scrotal ultrasound, those are not considered sufficient to affect fertility. But if you examine this male in a warm room and you can see the dilatation and you feel the bag of worms, so those are clinical varicoceles, they are likely to have an impact if coupled with abnormal sperm parameters. And therefore, doing a varicocelectomy can easily reverse their male infertility. Mumps, we've talked about it, you all know about it. The infection causes built-up pressure, and you see it's a compartment with the tunica giving sort of like a compartment syndrome. So there's damage from that. The blood testicular barrier is interrupted, and that's how they end up with infertility. So you find they have small shrunken testes because of the effect of mumps. What else is important? Oh yeah, I think I really want to touch about chemo and radiation. And why is that? Because whenever you find a male who needs to have oncology service, it's very easy to say, okay, now go see the oncologist, you need to have that. So you're always focused on the primary cancer. But have you ever thought, especially for the young man, that he may want to preserve his fertility? Maybe he does, maybe he doesn't, but I think it's very important to give that window of opportunity and allow them to do gamete preservation for future use, so that even if they have cancer treatment and it affects their sperm count and they get a partner lifelong and they want to have children, the sperm stored for them. Okay, so if you're part of your tumor boards, please be the champion for your patients in terms of fertility. Post-testicular, this is just the piping has a problem at some point, so blockages in the system due to infection or congenital anomalies like in cystic fibrosis, could have ejaculatory dysfunction, erectile dysfunction. I'll share with you, just recently I had a male patient who had azoospermia, and when we see that, we try and see where is the problem. Is it an obstructive problem, production problem? And in all that, in the investigations, found out that he was a diabetic, poorly controlled, and when he finally opened up, when he went to take a sample, he said, yes, the urge is there, like he's about to ejaculate, but nothing comes out, okay? So then what is the issue? I mean, he gets the erection, he has the sensation. Turns out he's having retrograde ejaculation because of autonomic neuropathy. So on that particular day, asked him to go and get a post-ejaculation urinalysis. And there they were, the sperms. You get happy when you see sperms wherever they are because you're just looking for them. So the urine had the sperms. So just to let you know that it's a real thing, and if you can look for what is the issue and address that, we give them hope. So in his case, put him on some medication to help with the muscle, so that the issue is there's no contraction of the muscle, they go back into the bladder. So we'll wait and see if that has an effect, but primarily his diabetes is out of control, that needs to be addressed. So this, I think we all know. How do we evaluate them? Sexual history, trauma in the past, are they on drugs, do they have systemic issues, what's their occupation, and then you examine them. I think we just say go for a seminanalysis. Learn to examine. You could get some clues right from testicular size, if they're small, shrunken, if you pick any, varicocele, and also look, do they have secondary sexual characteristics? Because that tells you they had minimal testosterone exposure at a very early age, meaning they didn't get their secondary sexual characteristics. So all those are really important for us. Good, so just to mention, evaluation, primarily seminanalysis. It'll guide you also, what else do I need to do, okay? If you get a normal semen analysis, you're good. If it's abnormal, what is abnormal? Is it the count, and how low is the count? Because the sperm count helps us not only to make a diagnosis, but it also helps us to determine what sort of treatment will be useful. You had the discussion about IUI. There's the sperm parameters. If we have just mild male factor, we can do IUI. But if you have severe male factor, you have azoospermia, you can't do IUI. So it helps to guide your treatment. And number two, it also helps in evaluating patients who've gone through vasectomy. You must document you had a negative seminanalysis. Otherwise, they do get their spouses pregnant. Ultrasound also has a role beyond just the testicular features, but if you do a transrectal ultrasound, you can also get additional details on the piping, if it's blocked or not. Good, so I think from here I just want to remind us that it's important to give the right instructions for semen analysis. How long have they abstained for? Because you can also get erroneous results because you didn't give the right instructions. And collection, how is it done? Through masturbation. Let's try and be kind to the men. Their facilities, they're told just enda kwa ile choo and then utoe sample. So imagine how psychologically, I don't know how you expect them to obtain a sample. I'm not affiliated too, but if you go to Third Park, for example, when you start feeling this is a bit too, the bed, I think you can almost rotate. There's a screen, there's magazines, and yeah, but I think it's all in terms of let's humanize it. It's already hard enough when you ask a man to produce a semen sample. I think that we all know about. Can I just share with you a bit of background from our facility with regards to semen samples? We looked at them over the last 2 years. We had 108 samples at Outspan Teaching and Referral Hospital. And that is how it looked for us. We had these were couples who had issues, not specifically men, but just couples who had an issue, and the man was asked to do a semen analysis. Thankfully, majority were nomosospermic. we had 15% of patients who are azoospermic. This is a little higher than the global prevalence, because when you look at the global prevalence, azoospermia ranked lower than oligospermia. Although our azoospermia was similar, but the oligo was less for us as compared to the global findings. So it's good to know what does it look like for us, and maybe that generates data as to our issues might be a bit different from the West or whoever, whatever data was used for pooling. Management, just highlighting the reversible factors, let's reverse them. So it's not always ART. Correct the hormonal system if you can. And today, you know, letrozole is not just for the women, it's also for the men. Because it has the same effect back to the hypothalamus, where it, it causes, blocks the negative feedback, so you have a higher drive of your FSH, LH, which drives spermatogenesis, if that is where the issue is. So it's not blanket, you need to know what you're treating. If it's an erectile dysfunction, we have treatment for that, but for severe male factor, we use ART. Testosterone should not be given to males desiring fertility. I think we need to be clear about that. You find a man, you know, poor sperm parameters, you do testosterone, you say, testosterone is low. Let's give testosterone to correct. You should never do that, because what does testosterone do? Goes back, hypothalamus, stops the production of FSH. You drive it down further, okay? Testosterone replacement is useful for, you know, puberty, the patients who have, you know, low testosterone, and you want to induce secondary sexual characteristics. So these are things you can do wherever you are in your clinics as we wait for our referral systems to be better. We want better structures whereby fertility is incorporated into public health facilities, private facilities, and we have a system where they move to tertiary referrals where the embryologists are and the specialists. So before that, work on obesity, smoking, caution about heat, look at environmental toxins, and caution about anabolic steroids and sleep. So as we finish, ART options, there are various, including IUI for mild male factors. We have IVF where it's moderate, and we have ICSI for where it's severe, where you have to go look for that specific sperm, which you believe is a good quality, and help it to fertilize the egg directly. So what are your take-home messages if you don't remember anything else today? 50% of infertility is contributed to by the male. Some causes are reversible. Let's look for them and reverse. Not everybody can afford ART, and it's not always indicated. Semen analysis, cornerstone. Get used to interpreting them. WHO has a very good document, the most recent, the 6th edition. It's very good for reference, and ART has truly revolutionized male infertility. Early evaluation and referral improves pregnancy outcomes. So those are some of my references. I'd like to make a special appreciation for Harley Street Fertility Center in an effort to improve fertility services out here, because not all patients can go and start doing their investigations in Nairobi and follow up. We have a partnership, Harley Street and Outspan Hospital. We run fertility clinics every quarter. And beyond that, we incorporate fertility patients into the routine gyne clinic. We do their basic investigations, workups out here, makes it cheaper for them, less cost of travel, less psychological stress of having to go to Nairobi. So it has really, really helped. We've had a few patients going in for IVF, and we're able to do all they need to do, and they just go for ovum pickup and the actual IVF. So thank you very much. Yeah.